Dr. Elise Héon, Ophthalmologist-in-Chief at the Hospital for Sick Children and longtime FFB family member. Dr. Héon is the chair of the RP conference tomorrow, and this is a role she has played for as long as I can remember. I'd like to invite her to say a few words about the importance of these educational forums.
So you see my name on things. I didn't always agree, but of course, with the charm of Anne and Sharon, I've never said no yet. Yet. Similar to tonight, they say you'll talk. I say, oh, okay. How about what? Well, tell them about everything that's going on. And I say, how much do I have? 5 minutes. But I have the microphone, so. So it's really nice to give you a sort of a token overview of what's happening in the field of treatments for retinal degeneration, since that's my topic, because there's a lot happening. And I know that many of you, and us too, feel too often that things are progressing at a snail pace. But I hope that I could put things in a perspective. I didn't do anything. I hope I can put things in perspective to show you that, in fact, it's not moving slowly, but it's moving safely. And our first driving principle is to do no harm, and you need to keep that in mind. And sometimes it's tempting to cut corners, but it would be a big mistake, the scientific and the clinical community, if we went that route. Just to put things in perspective, when I started in this business a few years ago in 1991, and this is a true story, we thought we knew it all. There were 2 genes that had been identified, RDS, and so we would say, we know everything about eye genetics, all we need is a treatment. And I think we should probably get there within 5 years. For some reason, 5 years is a magic number. So when you ask a physician, so when's the next thing, they always say 5 years. And so here we are in 2011, and I can tell you it's been a humbling journey, and I don't give any time frame anymore. And we've learned a lot. There's over 100 genes, so there's not 2 genes, and we're just starting to figure out what's going on. And what we've realized is that there's not going to be one treatment, but there's going to be a portfolio of treatments that's going to address different situations in different contexts. So just to give you an idea, that would include gene therapy for some, gene replacement therapy. Stem cell is going to play a role in another situation, retinal prosthesis in another situation. There's going to be some neuroprotective approach, the use of other medication, and so on and so on. And I've decided, since I only have 5 minutes, if you want to know all of it, you have to come tomorrow. I'll just give you a highlight of I would say, the most striking happening in the last decade, or probably even in our era of ophthalmology, and that is the role of gene replacement therapy. So the first clinical trial for gene replacement therapy is being held, has been going on since 2007, and it's for a form of very early onset retinitis pigmentosa, Leber's congenital amaurosis. And it's a very specific variant that's not even frequent. It's due to mutations in a specific gene, RP65. And I'll cut the story short. The story is very good, though, and will be revealed tomorrow. But the short version is that the first patient was injected in 2007. And since then, there's been 3 major groups across in North America and in Europe, and at least 30 patients have been treated. And all patients, if not almost all, have increased retinal sensitivity. But more importantly, the treatment has been safe. There's been no accident. There's been no adverse reaction. And so it's the first time, really, that we can say that gene therapy is applicable to disease for us and for inherited eye diseases. So that has been a very exciting journey. And moreover, the treatment, not only is it safe and it shows efficacy, but it's durable. So far, patients that have been treated 4 years ago seems to show the same effect than at day 1. or soon after. So this we call a proof of principle. And so we do have a proof of principle that it can be done. So now the frustrating part is you say, well, so what's next? So which one is next? And why don't you just copy paste? You have the recipe, you have the protocol, just get your act together and just redo it. And it doesn't work like that because every situation is different. The role of every gene is different, and every disease is different. And so in every situation, we need to start over, not from scratch, but there's really a lot of work to do. All that said and done, there's several diseases that are in the pipeline, and if you want to know which one, you have to come tomorrow. And because it's very exciting. So the good thing about the gene replacement therapy approach is that it's very specific, and so you target really what you want. So you know if it works, it's really going to work. The disadvantage of this approach is because it's specific. So you target a smaller population. So it becomes very expensive. So just to give you an idea, for one center, for one of the Philadelphia group, for the LCA trial, the phase 1, which is just the toxicity part, cost at least $10 million. That's just the human part, okay? That's not all the studies that preceded that. And the estimate for phase 2 is between $15 and $20 million, and that's considered probably an underestimate. So this type of achievement cannot be done without support and without research. And hopefully, with more research, the costs will go down. We'll figure out a way to be more effective. But to date, for the next trials that are being planned, it's about in that price range that we're talking about. So it's a lot of money. So I would just like to leave you, since I only have 5 minutes and I'm probably done, but I want to tell you a story that for me was really important with the way the day I was told the story. And what I've learned through this business is something that we don't talk about much, is the expectation. And so people say they're frustrated and of all this era of new treatment, we never talk of what's the expectation. So one of the first patients that was treated by my colleague, Sam Jacobson, according to Sam, he has one of the best responses. And the man was angry at him in follow-up, and Sam didn't understand. He says, I've been following you for 25 years, for God's sake. I gave you the treatment, and you have improved retinal sensitivity, and why are you mad at me? And he says, well, I thought that I could be a train conductor. You told me it was a treatment. I assumed it would fix everything. And I can only encourage you to talk about expectations and what is really a treatment. So for some, a treatment could be a small improvement, a big improvement, could be just slowing things down or just protecting things. And so the language is a bit aloof and merits clarification. So I think that if you understand the vagueness of some of these situations, the frustrations go down, and you have a better appreciation of what the possibilities are. So I think I'll stop here, and I hope I'll see you tomorrow if you want to hear the other stories, because I have more stories. Thank you.